Hello all, welcome to the discussion on surgery for EMREE. First we'll walk through the syllabus for the exam. It's given in a very detailed manner in the EMREE blueprint, which is given in their website. So from the basic principle to the acute care and different system, there is a wide, varied topic. So just go through the syllabus before you start your preparation so that you know what are the topics that you need to understand and be aware of. So this is just a few slides for the syllabus. So the basic principle like surgical infection and antibiotics, you have to know about the SIRS response, what is the difference between SIRS and shock and sepsis, how surgical infection, what are the antibiotics used, what are surgical site infections, what are the intra-abdominal infections, how do you treat them, what are the common infections of skin and soft tissue, including your necrotizing fasciitis, cellulitis, Erysipelas, and those things. How do you do a pre-operative evaluation and the risk assessment? What about the anesthesia, local and regional? How do you monitor the patient, and what are the usual drugs used for pain management? In the wound care, what are the phases of wound healing? What are the factors affecting wound healing? What about abnormal wound healing? And how about wound dressing, like negative vacuum dressing, negative pressure dressing? Post-operative complications like post-op fever. What are the common causes of post-op fever on different days? What about DVT and complications of common procedures? In general surgery, coming to breast, they talk about nostalgia, nipple discharges, breast mass. How do you approach breast mass in pregnancy? What are the benign breast disorders which are proliferative and non-proliferative? Breast abscesses and mastitis. How do you screen for breast cancer and breast cancer per se? Then thyroid and parathyroid. How do you evaluate a neck mass? For a thyroid nodule, how do you approach, how do you differentiate a cold nodule, hot nodule, usually for hyperthyroidism, how do you approach, and hypothyroidism, how do you approach? What is the surgery for hypothyroidism? Thyroid cancer, complications of thyroidectomy, primary hyperparathyroidism, secondary hyperparathyroidism, and tertiary hyperparathyroidism. You have to know the differences between them. They usually give a scenario with the lab values, and you have to differentiate between all of that. Coming to adrenal, surgical hypertension and incidental adrenal mass. In GI, GRD, corrosive esophageal injury, swallowing of foreign body, esophageal cancer, upper GI bleeding, peptic ulcer disease, surgical management of obesity, lower GI bleeding, appendicitis, bowel obstruction, IBD, colon cancer screening, colonic polyp, colon cancer per se, diverticular disease, PR bleeding, anorectal conditions, and pilonidal sinus. Hepatobiliary, biliary colic, acute cholecystitis, obstructive jaundice, cholangitis, hydrated liver disease, liver abscess, acute pancreatitis, chronic pancreatitis, and pancreatic cancer. Then hernia, you have to know in and out of hernia, inguinal hernia, the difference between inguinal and femoral hernia, the different types of inguinal hernia, direct and indirect, how do you differentiate and identify them? What are incisional umbilical epigastric hernia? What are obstructed hernia, strangulated hernia, incarcerated hernia? The different terminology you have to know. What is a rectus sheath hematoma? Then other named hernias, there are many like Camian, Richter, sliding, Litter, there's so many. Then skin and subcutaneous lesion as mentioned previously, cellulitis, necrotizing fasciitis, lipoma, tetanus prophylaxis, soft tissue sarcoma, and other skin malignancies also you have to know. Vascular surgery, diabetic foot, peripheral arterial disease, acute limb ischemia, what is chronic limb ischemia, and what is critical limb ischemia. And ABVP, that is angle brachial pressure index. Angle brachial pressure index, ABPI. Okay, that's also you have to know. Venous disorders, varicose venous thromboembolism, and others like compartment syndrome, gangrene, dialysis, vascular access, and abdominal aortic aneurysm. Coming to pediatric surgery, branchial cyst, thyroglossal cyst, pyloric stenosis, diaphragmatic hernia, tracheoesophageal fistula, umbilical hernia, undescended testis, and how do you manage them? Hirschsprung, usually associated downs, whims, neuroblastoma, circumcision. Plastic surgery, hand infections, finger injuries and amputations, carpal tunnel syndrome, upper limb injuries, nerve evaluation, and cutaneous melanoma, squamous cell carcinoma, basal cell carcinoma, burns, and red zone. Trauma and acute care, like initial assessment of a trauma patient, how do you manage the airway, life-threatening injuries like airway obstruction, tension pneumothorax, cardiac tamponade, chest trauma, shock, abdominal trauma, pelvic fracture, head trauma, spinal injuries, and what do you do in all those injuries? Musculoskeletal trauma, trauma in extreme age and triaging. GI bleeding, upper GI bleeding, lower GI bleeding, all the causes and surgical management of both. Specific organ trauma like liver, spleen, kidney, you have to know the grades of the injury and what do you do in each of them. And the retroperitoneal, esophageal, gastric, and bowel trauma, and damage control surgery. Surgical ICU, abdominal compartment syndrome, lung protective ventilation, early and adequate nutrition, restrictive blood transfusion, DVT and stress gastritis prophylaxis, source control in septic patients. Acute surgical condition like acute abdomen peritonitis, mesenteric bowel ischemia, perforated viscous. And urology, like emergencies, acute urinary retention, testicular torsion, hematuria, fornius gangrene, priapism, infection, cystitis, pyelonephritis, prostatitis, epididymoorchitis. Lower urinary tract obstruction, benign prostatic hyperplasia, urethral stricture, upper urinary tract obstruction, urolithiasis, and retroperitoneal fibrosis. Then pediatric urology, like uretropelvic junction, vesico-ureteric reflex, uretrocele, and posterior urethral valve. Neurosurgery like raised ICP, cerebrovascular disease, spinal cord compression, entrapment neuropathy, cranial spinal infection, hydrocephalus, communicating and obstructive, degenerative disc disease, congenital anomalies, and brain tumors. We have to know the benign and the common site of brain tumors. Trauma, open fracture treatment, compartment syndrome, principles of fracture dislocation management, oncology, osteosarcoma, Ewing sarcoma, chondrosarcoma, birth injuries, and developmental diseases. ENT also have a couple of topics: epistaxis, otitis externa, media, sinusitis, tonsillitis, acoustic neuroma or vestibular schwannoma, which is at the CP angle, foreign body, disorders of balance, and hearing loss. Ophthalmology, infectious inflammatory disorders like blepharitis, conjunctivitis, uveitis, and ophthalmitis. Iridocyclitis, periorbital cellulitis, uveitis, neoplasms like melanoma, retinoblastoma, cataract, glaucoma, lacrimal system disorders, refractive disorders, disorders of retina, diabetic retinopathy, papilledema, retinal detachment, retinitis pigmentosa, retinal hemorrhage, amaurosis fugax, and visual impairment and blindness, night blindness and loss of vision, traumatic and mechanical disorders of corneal aberration, ulcer, dislocated lens, foreign body eye, laceration of the eyelid, and subconjunctival hemorrhage. So that's been a lot of the syllabus. I just wanted to know that there's a complete breakdown of the syllabus they've given, and if you focus on these topics, if you try to make sure that you know these, I think you can ace the exam. So let's get started. We're coming with the certain basic principles. So what is the systemic inflammatory response syndrome, SIRS, sepsis, severe sepsis, and what is septic shock? So coming to SIRS, what is SIRS? It means there is a temperature, there's pyrexia or hypothermia. Okay, it's either more than 100.4 Fahrenheit or less than 96.8 Fahrenheit. Respiratory rate is more than 20, so there is tachypnea. Heart rate more than 90, there is tachycardia. WBC again more than 12,000 or less than 4,000, so there is either neutrophilia or neutropenia, or leukocytosis or leukocytopenia. 10 more than 10% bats, PCO2 less than 32. So this is the criteria for SIRS. So there is temperature, tachycardia, tachypnea, total count is high, and PCO2 is low. When coming to sepsis, any of the two SIRS response with a confirmed or suspected source of infection. So there is a source of infection, either UTI or pneumonia or an intracranial infection or an intra-abdominal infection. There is some kind of an infection, okay, with two cells response. That's called sepsis. When do you call severe sepsis? So along with sepsis, that is two cells response with the source of infection, there is also end organ damage. End organ damage like AKI, okay? For example, AKI, you call that severe sepsis. In that, there is hypotension and there is lactate, okay? Lactate is high also in shock. So what differs severe sepsis and septic shock? Septic shock means the severe sepsis with persistent signs of end organ damage, hypotension and lactate. So shock can be different things. It can be septic shock, it can be hypovolemic shock, it can be obstructive, cardiogenic, neurogenic. We'll come to shock at a different point, but here I have to highlight on the difference between sepsis and septic shock. Then how do you prevent surgical site infection? So pre-operatively you can focus on the asepsis precautions, full body wash. You can prepare the surgical site immediately before incision. Completely aseptic precaution. You have to decontaminate the hand. Remove hair on table with electric clippers if available. Perioperatively, you have to maintain the saturation more than 95. Monitor and correct blood glucose. Okay, maintain your glycemia, maintain normothermia. Okay, because hypothermia, hyperthermia or hyperpyrexia is also bad. Then adequate antibiotic prophylaxis. So antibiotic has to be of the right choice, has to be given for the right duration, has to be given at the right time. That is three things. The right time, the right antibiotic for the right duration. So use prophylactically for clean, contaminated or dirty surgery. We'll talk about this later. What is clean, contaminated and dirty wound? We'll talk about this. So you use antibiotic prophylaxis for all the type of wound except for clean wounds. For clean wound, you may not need antibiotic prophylaxis. So you have to select according to the guidelines based on the site of the operation and the local resistance pattern, and administer usually within 60 minutes before the incision. And that also varies slightly depending on the half-life. And if it's a very long operation, you have to repeat the dose if it has a lower half-life. And it's usually recommended that it's given 24 to 48 hours, because giving beyond 48 hours doesn't add on any have any add-on benefit. So it is usually given 24 to 48 hours. Okay, I've just added a slide. You can just remember this because I have seen some questions on the mechanism of action of some of the antibiotic. So cell wall synthesis inhibitors usually given for gram-positive organism who have a peptidoglycan cell wall. So that is penicillin, cephalosporin. Others like vancomycin usually given for MRSA, then bacitracin. Then protein synthesis inhibitors which interfere with either 50S or 30S of ribosomal RNA, which are a tetracycline, aminoglycoside, macrolide, chloramphenicol, and clindamycin. Folate antagonists are the drugs that inhibit the folate synthesis, mainly sulfamethoxazole, trimethoprim. Then quinolones. They are DNA gyrase inhibitors like Ziplox, levofloxacin. Nitroimidazole, it's metronidazole. RNA polymerase inhibitor is rifampicin. Mainly cell wall synthesis inhibitor. You have to know protein synthesis inhibitors. Then you have folate antagonist. You have your quinolones, which are DNA gyrase inhibitors, and RNA polymerase inhibitor, which is your rifampicin. Okay, then there is also classification like bacteriostatic and bactericidal, something that kills the bacteria, bactericidal, something that only restrict their growth is bacteriostatic, or arrest their growth is bacteriostatic. So as mentioned before, we have 4 different types of wound. That is clean wound, clean contaminated wound, and dirty wound. So clean wound means there is no sign of inflammation, no opening of the respiratory tract, food or genital or urinary tract. Example is inguinal herniorrhaphy. That is a clean wound. There, the risk of infection, surgical site infection, is very, very low. Then clean contaminated wound. Here, the less than 2%, less than 10%. This is from the past statistics, I think. With the advent of antibiotics and adequate use of antibiotics, this has been further reduced, to less than 2%, even less than 1%. Okay. Then coming to clean contaminated or potentially contaminated, there is opening of respiratory tract, food, genital or urinary with no significant contamination as such. So it is cholecystectomy without overflow bile. But if it is cholecystectomy with overflow bile, the nature of the wound changes. Then what about contaminated? Then that means inflammatory process or opening of respiratory tract, like appendectomy, colectomy. Okay. Dirty wound means there is obvious, like perforated bowel. If you're operating on a perforated bowel with fecal peritonitis, that is obvious dirty wound. Cause contamination secondary to pus or drilling. That is cholecystectomy by cholecystitis, acute with empyema. Okay, so these are 4 types of wound. Uh, Coming to surgical site infection. So we have different layers of our body. First is our skin. Skin again have, as you know, it has epidermis, that is the topmost layer. Okay. Lower down you have dermis. Okay, epidermis, dermis. Then you have the subcutaneous tissue. Then you have the deep soft tissue, which is your fascia and your muscles. And you have organ or space. Okay, so the surgical site infection is divided into superficial incisional surgical site infection, which includes the skin and subcutaneous tissue. Deep incisional means it includes a muscle and fascia as well. Organ or space means it is even deep down, involving the organ or space. Okay, it may or may not involve the skin and upper layers. It just involves the organ or space. Okay. Then so you have to treat accordingly, like superficial and deep. Then a word on intra-abdominal infection. Intra-abdominal infection, usually you have to first uh, resuscitate the patient, usually with a 30 ml per kg of crystalloid, and then at most important is source control. So in infection or sepsis, whenever possible, you have to do a source control. Like for example, if there is an abscess, you have to do an IND and then give antibiotics. Just giving antibiotics will not help in so many of the infections where there is an obvious source, like in a necrotizing fasciitis. If you're giving antibiotic, it may not work. You have to debride. You have to sometimes go for an amputation. So that is the case. So you have to do a source control. You can do a very localized source control, like a percutaneous drainage in case of a very localized infection, like subphrenic abscess after splenectomy, pelvic abscess following perforated appendicitis, or diverticulitis with localized abscess. Diverticulitis again has different class, like Hinge classification. We'll come to that when we are dealing with diverticulitis. Or you have to go for an operative intervention for poorly localized or diffuse collections or necrotic tissue or inaccessible collections. And usually in intra-abdominal, you place a drain, and that is done in a gravity assisted manner. And the placement of drain, the choice of the drain also uh, uh, you know uh, plays a significant role in reducing the post-operative complications. And you always have to decide, if it's a very contaminated thing, you don't close, you don't do anastomosis, because it's said that an anastomosis is that is never made never leaks, because there is a post-anastomotic leak is one of the main complications. So if it is highly contaminated, do not go for anastomosis straight away. You usually leave a resect and do an external stoma. Okay, so that is about intra-abdominal infection. Now coming to skin and subcutaneous tissue infections, we'll see the layers of skin, layers of epidermis first. So we have 5 layers, which is called stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and stratum basale. In that you have to remember that the melanocyte, you see here, melanocyte in the basal and also in the spinosum layer. Okay, that's where melanocytes are. You can see the cell is here. The melanin pigments are all in the spinosum layer. The topmost layer is the keratinocyte. Okay, and with the basal layer. Okay, so this is the layers of skin. So we'll come to each of the skin and subcutaneous tissue infections. So coming to impetigo is a bacterial infection, usually in children. It's caused by Staph aureus or group A streptococci. And the classical thing is they have a honey colored crust. That is the key word in the question. And the treatment of choice is either topical antibiotic like fusidic acid, or you can give, in severe cases, you may go for flucloxacillin, which is given for Staph aureus. Okay, next we are coming to folliculitis, furuncle, and carbuncle. So folliculitis, it's a papular or pustular inflammation of the hair follicles only. So they are very discrete, single thing, and you can see here clearly that is out of this pustule there is a hair coming out. That means it's a hair follicle. But about furuncle, they are even more painful, firm or fluctuant abscesses, which is again originating from a single hair follicle. So that has now become an abscess. Okay. What about a carbuncle? It is a network of furuncles which are connected by a sinus tract. So I think you now understand the clear difference. So a single hair follicle, when it is affected like a pustule or a papule, it's called a folliculitis. When it is becoming an abscess, okay, it is called furuncle. When the abscesses are connected by a sinus tract, it's called a carbuncle. We'll see again. Okay, so this is 1 mm perifollicular papule or pustule. I'll clearly show the difference between what is a papule, pustule, and different other terms in the next slide. So this is a papule or a pustule, usually in the areas of sweat, and there is an aberration. Treatment is tetracycline or erythromycin. Now, furuncle, it's a 1 centimeter tender red papule or a fluctuant nodule. You have to do IND because it's an abscess, and dicloxacillin for 10 days or augmentin for 10 days. Here this is a carbuncle, which is collection or a coalition of many furuncle. It's several centimeter diameter, red plaque, usually in the nape of neck. Incision and curettage and excision, and incision and curettage or excision. Okay. And it is treatment of choices dicloxacillin. I'll tell the different terminology that we use for any abnormal area of skin. So what is a macule? Macule is only flat, it's not raised, and less than 1 centimeter. It's a clear border. Okay, if it's hyperpigmented, you call it a hyperpigmented macule. Okay, if it's hypopigmented, you call it a hypopigmented macule. The macule term itself doesn't mean it's hyperpigmented or hypopigmented. It just means it's a flat lesion with a clear border of less than or equal to 1 centimeter. What about a patch? It's more than 1 centimeter. It's a macule, but it's more than 1 centimeter. So that then you call it a patch. So if it's a hyperpigmented, you call it hyperpigmented patch. Hypopigmented, like you see in leprosy, you call it a patch. If it's less than 1 centimeter, you call it a macule. What about papule? When coming to papule, it becomes raised. They are raised bumps, again less than 1 centimeter. What about a plaque? They are papule, but more than 1 centimeter. So they are raised skin lesions more than 1 centimeter. What about a wheal? It's smooth, papule or plaque, but they are transient. Transient usually, allergic reaction like urticaria, you can have wheals. What about a pustule? Pustule, they contain pus. Okay, that's called pustule. What about vesicle? They contain only clear fluid. Okay, clear fluid. Blisters with pus is called pustule. Blisters with fluid is called vesicle. What about bullae? They are fluid-filled blisters more than 1 centimeter. Okay, if it's small, it's a vesicle. If it's large, it's called bullae. What about scale? They are accumulations of thickened skin which become dry or flaky and they peel off. That's called scale. You can see it in psoriasis, like in flannels and all. What about a crust? They are dry exudates, like you saw, say honey-colored crust, which is seen in Impetigo. So that they are dry exudates, and the liquid leaks out of the blood vessel. Exudates of the liquid that leaks out of the blood vessel. So that is called a crust. So macule, patch, papule, plaque, pustule, vesicle, bullae, scale, crust, wheal. I think that's clear. Now coming to cellulitis. Cellulitis is an inflammation of the dermal and subcutaneous tissue due to non-suppurative bacterial invasion. Usually by group A, Streptococcus or Staph. The affected part is, so it is a more deeper down to the dermis and subcutaneous tissue as well. And the affected part is warm, swollen, tender. There is pitting edema or brownie induration. The regional lymph nodes will be enlarged and tender with acute lymphadenitis also. You have to do a calf tenderness test to rule out DVT. So if the calf tenderness is positive, it may be DVT. Because DVT also there is swelling, edema. But if there is a deep venous thrombosis, you have to rule out, because it's more, the line of management also differs, because cellulitis is a bacterial infection. You have to give antibiotics. If it's spreading, you have to look for the spread. But for DVT, the line of management is different. So you have to rule out DVT. The first line is rest and elevation of the part to reduce the edema. Appropriate antibiotic, preferably broad spectrum. Then pain relief. Failure if inflammatory swelling to subside after 48 to 78 hours suggests that the cellulitis has now turned into an abscess, and then you have to do an IND under GM. Okay, then we'll come to erysipelas. We'll see the difference between cellulitis and erysipelas. So erysipelas is more of upper dermis and superficial lymphatics. Okay, lymphatics are also affected. There is no subcutaneous tissue involvement, because and it's more superficial than cellulitis. Streptococcus is the causative organism. The appearance is rosy rash, which disappears on pressure, and it feels stiff. Okay, so the raised rash of erysipelas, they have a sharply defined margin, which is better felt than inspected, rather than a cellulitis, which is like a diffuse thing, and it's more deeper than erysipelas. Erysipelas is more superficial, and it also involves the lymphatics, and it has a sharply defined border, which is more felt than inspected. Coming to necrotizing fasciitis. Necrotizing fasciitis, it's more severe and more extensive. It can spread both up and down. Okay, so it is necrosis, extensive necrosis of the superficial fascia and subcutaneous fat with destruction of this tissue, and they can spread superficially as well as deep down. So organism, they spread initially from the subcutaneous tissue along the superficial as well as the deep plane, facilitated by bacterial enzyme and toxin. The infection can cause vascular occlusion, ischemia, and necrosis. The superficial nerves get damaged. They produce anesthesia. Then septicemia ensues. So it's more severe and more extensive, and it can spread both up and down from the subcutaneous tissue. So there is ulceration or blisters, and there is liquefactive necrosis. So necrotizing soft tissue infection, they are rapidly progressive infection with extensive destruction of the soft tissue. You can see that it spread from the subcutaneous tissue. Okay, if it involves a fascia, it's called fasciitis. Muscles, myositis, in going up, involving the dermis with the subcutaneous tissue and epidermis, it's called cellulitis. So it's more extensive, more severe. Okay. Then coming to Clostridial myonecrosis. So Clostridial myonecrosis is different from necrotizing fasciitis. Here the causative organism is Clostridium uh, perfringens, Clostridium perfringens. The presentation is there is severe pain out of proportion to the clinical findings. So the clinical findings are less than even a necrotizing fasciitis, but the pain is out of proportion. There is erythema or cutaneous blisters. There can be gangrene. There is crepitus due to the air, and a brown foul-smelling discharge or loss of motor function. Penicillin is given as an adjuvant. Treatment is surgery. So the treatment is surgery, and penicillin is given as an adjuvant. In addition to surgery and antibiotics, hypercarbic oxygen or hyperbaric oxygen therapy is also used because it inhibits the growth and kills the anaerobic Clostridium perfringens. So Clostridium, since it is anaerobic, you can also give hyperbaric oxygen therapy. The treatment is surgery. The pain is out of proportion. There can be gangrene and crepitus and blisters. Okay, that was all about the mainly superficial infections and things. We'll continue with the rest of the thing tomorrow. Thank you all. Uh, keep following, keep updated with the topics, and keep learning. All the best for your exam.